This presentation is about the current management of nephrotic syndrome in children. I'll briefly talk about the management, not so much about the mechanisms and the theoretical aspects. Nephrotic syndrome is a common problem in children worldwide. It needs expert long-term management, treatment and care. But in most cases in children, there is complete recovery. And with proper management, treatment, complications can be avoided, and normal growth and development of the child is ensured until the complete cure takes place. We know that the features of nephrotic syndrome result from heavy proteinuria. Now, the proteinuria is a very complex phenomenon. We know that the filtration of protein across the glomerular capillary wall is a very complex process, depending upon the molecular size, shape, electrical charge, intraglomerular capillary hemodynamics, and so on. Now we realize that there is a crucial role of podocytes and food processes. These control the movement of the proteins. Now there are several proteins which control the structural, functional, and integrity of a microskeleton. Gene mutations have been known which can lead to massive proteinuria. Commonly NPHS1, NPHS2 are involved in the congenital nephrotic syndrome. Now we believe that podocyte is a main component of glomerular filter in minimal change nephrotic syndrome and FSGS. Many of these conditions are now grouped as podocytopathy. It's been hypothesized for some time that there may be a circulating factor which may be the actually proximate cause of podocyte injury and proteinuria. A number of agents have been proposed which may be causing all this, but none has been identified. And it's also believed now that various medications that abolish or reduce proteinuria may actually be targeting podocytes. Now, clinical and laboratory features of nephrotic syndrome, starting with edema, which may be mild to massive. It's insidious at onset, coming in the morning and then gradually going away toward the evening. But with time, it becomes persistent, and unless controlled, it becomes very massive. Occasional child may have hypertension. On lab testing, urine will show 3+ or 4+ protein. Quantitatively, it can be measured as more than 40 milligram per meter square per hour or more than 100 milligrams per kg per day. An occasional patient may have microscopic hematuria. The important features are hypoalbuminemia. The serum albumin level often are falling below 2.5 or so, and there's hyperlipidemia. The blood cholesterol levels are sometimes as high as 300 or more. Blood urea and creatinine levels are usually normal. Now, nephrotic syndrome can be idiopathic or primary in about 90% of children, and about 10% may show an underlying cause called as secondary. Secondary nephrotic syndrome shows a variety of underlying disorders. Some are listed here. Congenital nephrotic syndrome caused by torch infections, Finnish type nephrotic syndrome, syphilis, systemic vasculitis like Henlock-Schönlein, purpura, polyangiitis, systemic lupus erythematosus, amyloidosis, post-streptococcal and post-infections glomerulonephritis, IgA nephropathy, and some African countries, Plasmodium malariae infection. Now, if one suspects that there may be a secondary nephrotic syndrome, an underlying cause for it, then this child must be referred promptly to a pediatric nephrologist because it will need very detailed evaluation and most likely kidney biopsy. Now, when you see a child, initial evaluation is limited, not very extensive. Age, 6, a family history of kidney disorder, blood pressure, urine examination for protein and RBCs, blood urea and creatinine levels, serum C3, and a careful assessment of all these findings will indicate the likelihood of steroid response in nephrotic syndrome or steroid-resistant nephrotic syndrome. Now we coming to idiopathic nephrotic syndrome. There are two very broad groups. One is the steroid-sensitive or minimal lesion. The other is steroid-resistant or non-minimal lesion. The former, the steroid-sensitive nephrotic syndrome, the onset is usually between the ages of 2 and 6 years. Boys have more preponderance, 2.5 to 1. And hematuria is absent, blood pressure is normal, blood urea is normal, and serum C3 levels are normal. Whereas in a steroid-resistant nephrotic syndrome, which is mostly non-minimal, the onset is usually in older age. Sex distribution may be about equal. These patients may have microscopic hematuria and occasionally gross hematuria. They may have hypertension. Blood urea level may be increased, and in some cases C3 may be decreased. Non-minimal lesion nephrotic syndrome is a heterogeneous group, and in some patients, some cases, genetic abnormalities are being found. There may be occasional familial forms. We do a biopsy in these patients, and three common renal histological patterns are focal, segmental glomerulosclerosis, mesangial proliferative nephritis, and membranoproliferative. Most of these will be steroid resistant. Out of all these, FSGS is most common, and it presents a treatment challenge. Now again, if non-minimal lesion is suspected based on the clinical and lab evaluation, these children should be referred to a pediatric nephrologist because they will need more detailed investigations and renal biopsy. One example is shown here. This is mesangial proliferative nephritis, showing pockets of proliferation and a small crescent on one side in 3, 4, 5 o'clock positions. Very, very briefly mentioning about steroid-resistant nephrotic syndrome. Now, these patients will not respond to prednisolone with their remission. The dose mentioned here, a full dose of 2 milligram per kg or 60 milligram per meter square per day for 4 weeks. Now, if the child does not respond to it, he will be classified as steroid resistant and needing further dose. We must ensure that the child has been taking adequate dose. We exclude infections, control edema, and ensure compliance with treatment. Now, steroid-resistant nephrotic syndrome are about 5 to 10% of all idiopathic nephrotic syndrome in children. Biopsy, as mentioned, in about 10-15%, although the patient is steroid resistant, the biopsy may still show minimal change. But in the majority, we will find these FSGS, mesangial proliferative, and rarely some others. Now, treatment of this group of patients is unsatisfactory, is empirical. There are no definite guidelines. There are various regimens tried, listed here: IV methylprednisolone, 3 pulses, oral or intravenous cyclophosphamide in those with minimal change. Intense immunosuppressive regimen is not used in these patients. We go on to cyclosporin and tacrolimus, and finally rituximab. Now, the KDIGO recommendations are that we use calcineurin inhibitors like cyclosporin or tacrolimus as initial therapy for this group of patients, and they can be combined with low-dose prednisolone. We use for a minimum of 6 months and stop if there is partial or complete remission is not achieved. But beyond this period is not recommended. And if they respond even partly, we use them for a minimum of 12 months and combine these with ACE inhibitors and angiotensin receptor blockers. Now, the patients, the group of patients who do not respond to calcineurin inhibitor, again, it's very difficult. We use mycophenolate with prednisolone. We use non-specific measures to reduce proteinuria, ACE inhibitors, AT2 blockers. We treat hypertension and control hyperlipidemia. A few words about focal segmental glomerulosclerosis or FSGS. Occasionally, this lesion may be secondary, and this is due to reflux nephropathy, extreme obesity, HIV infection, low birth weight, and so on. But most of the patients in children are idiopathic. Again, it's a heterogeneous. It can be genetic, familial. It's not a one uniform condition. There are histologic variants, lesions being in the hilar. There is a collapsing variety, which is particularly serious. And genetic forms are resistant to treatment. So we do not recommend immunosuppression in these patients. But surprisingly, these children, the genetic variants, they do not recur in transplant. Why the usual kinds, they have a very high recurrence rates in transplants. Lesions shown here, one half of the glomerulus is quite normal, but on the other half you can see the typical sclerotic lesions. Now with aggressive treatment, 50% patients in the group of patients may achieve either partial or complete remission. Complete is of course uncommon, in partial relation. Relapses will occur after steroid treatment, and again we manage these patients symptomatically, supportively. Long-term prognosis in this group is uncertain, but there are individual variation, and these probably may be related to renal histology, etiology, or genetics. We talk now only on steroid-sensitive nephrotic syndrome. We also call as minimal change nephrotic syndrome or MCNS, and this is the commonest group in children. About 90%, 85 to 90% of all children with nephrotic syndrome will fall into this category. As I mentioned again, the etiology remains unknown. The long-term course is variable, but there is eventual complete recovery in most cases, and this is the most positive, most encouraging factor in the management of these patients. And again, it needs expert management over a long period of time to avoid complications and morbidity. Lesion shown here looks quite normal, but this patient has classic nephrotic syndrome, massive proteinuria, usual features. Initial management in these patients, I think, is very important to explain and inform the family and answer their question up front. Do not leave it toward later. Even on the first visit or second visit, we try to explain everything. We treat the child if he has infection. Usually patients may have infection, either chest infection or some other. We control that and reduce edema. Sometimes the patients come with massive edema right in the beginning, so that has to be controlled. And once we have done that, we start the prednisolone treatment. This standard regimen is 2 milligram per kg per day or 60 milligram per meter square. Maximum dose is 60 milligram per day, as either a single dose or divided doses. And we give this treatment initially for 6 weeks. 6 weeks of daily treatment, followed by 1.5 milligram per kg, or we can do this on a per meter square area also. And again, this alternate day regimen is for 6 weeks. We use antacids if needed. We give calcium and vitamin supplements. Now, initially we were using 4-week daily plus 4-week alternate day ISKDC schedule for quite some time. Now it's not adequate. So initial minimum treatment is 6 weeks daily plus 6 weeks alternate day, total of 12 weeks. And recommendations are that after this you stop the dose and see what happens. But some centers are using a tapering dose of alternate day dose over another 3 months. So the total is 12 week plus 12 week. There is no clear proof that this is very beneficial, but I think there are center-to-center variation. Long-term benefit of prolonged treatment is not proven, but again depends upon the experience of the clinician, how he manages it. Side effects of prednisolone listed here: Cushinard features, hypertension, obesity, hirsutism, stry, sometimes behavior changes, and it can be quite prominent in some cases. Now, side effects are appropriately managed, but explain the need of high-dose therapy and inform the expected side effects to the family, to the parents, reassure, and besides talking explaining all this, we give them some kind of literature which is available now. We have booklet of this kind in different languages. These are meant for parents and explaining the very basic things, so they are not misled by others. They understand what is the problem. The difficulty in these group patients that once we have stopped the initial treatment, most patients will relapse. They will be in remission for some time, but eventually many patients relapse, and the pattern is listed here that infrequent relapses, 2 relapses in 1 year or less than that in about 30%, but frequent relapses, more than 3 relapses in 1 year in about 45%. And about 20% patients will be steroid dependent. These are the more difficult ones. They will get relapse as soon as you taper the prednisolone dose or stop it. Now, relapses are usually following upper respiratory infection or some other infection. We can observe for some time, and if the child gets transient proteinuria for a few days and resolves itself by itself, it is not significant. Now, we explain to the family to examine the urine by using the dipstick method and monitor the protein testing, and we treat URIs appropriately, and occasionally relapses may be prevented or aborted by increasing the dose to the alternate day dose to daily dose for 1 year or so, 1 week or so. We start treatment when there is mild edema. We must not allow, I repeat this, we must not allow large amount of swelling to appear. And the treatment of relapse is prednisolone 2 milligram per kilogram daily until urine protein shows trace or nil for 3 days, then 1.5 milligram on alternate day for 3 months, and then we stop it. Normal routine of child should not be interrupted. He will be continuing to go to school. There are no restrictions, and he is allowed to have a normal kind of routine. Now, if there are frequent relapses, then initially what we do is to try to use a small dose of prednisolone, like mentioned here, 0.7 milligram per kilogram or lower for 1 year. But if this is not effective, if alternate day treatment is not effective, we might use a small dose daily, but treat relapse with a daily regimen. If there is a full relapse, we give the short time prednisolone full dose to control it. We monitor growth. We must avoid significant steroid toxicity, and if there are major side effects, we use other medications. Now, serious side effects of corticosteroids are listed here: cushingoid obesity, glucose intolerance, growth retardation, hypertension, behavior problems, cataract, glaucoma. Now, these are extreme examples. We must not allow this to happen. This is a little girl, you can see the changes. She stops going out, everybody points at her. This is a failure of management. This must not be allowed to happen. Same child with proper treatment, you can see that if even now she looks a little cushingoid, but nothing like what she had before. See this child with massive edema and massive cushingoid features. See the striae and so on. Again, this is a failure of management. This must not be allowed to happen. See here, the striae and so on. Now, treatment options for this group of patients are listed here. We have very few medications, and they are tried about in this order: levamisole, cyclophosphamide, chlorambucil, mycophenolate, cyclosporin, tacrolimus, and finally rituximab. These are the limited armamentarium that we have at our disposal. Levamisole is a strange kind of a molecule. It is immunomodulatory, and the dose we use is 2.5 milligram per kilogram per day for 1 year or more. This is given on alternate days, and prednisolone may be combined with this in a small dose for a long time. It has hardly any toxicity, and its efficacy is limited. I think in about 50% of patients, it can control the problem on its own. Failing this, we use cyclophosphamide. The dose is 2 milligram per kg per day for 12 weeks, perhaps now we're using for 12 weeks. The maximum cumulative dose of 160 mg per kg is supposed to be safe and doesn't cause any gonadal toxicity. We start treatment while the child in remission, and combined with the alternate day prednisolone, we maintain a high fluid intake to prevent hemorrhagic cystitis. Neutropenia can be watched if the total TLC falls below 4,000. We discontinue cyclophosphamide for a week or two and again start. Chlorambucil is not used. Cyclophosphamide is the preferred drug. Failure of cyclophosphamide to control, we use mycophenolate. There are a number of studies showing the efficacy. The dose mentioned here, 1200 milligram per meter per square, 2 divided doses for about 1 to 2 years. Side effects are limited, they are not very serious. Occasional abdominal pain, diarrhea, and there is no nephrotoxicity. Now, mycophenolate is again not effective in every case. So we use cyclosporine, tacrolimus. These are calcineurin inhibitors. The dose of cyclosporine mentioned is 0.5 milligram per kg per day in 2 divided doses. And we start with a little high dose and then bring it down to maintain remission. The side effects are hirsutism and gum hypertrophy. Sometimes they can be very severe, especially in girls. Tacrolimus has a similar mode of action. Dose is 0.1 to 0.2 milligram per kg in 2 divided doses. And we try to maintain a blood level of 5 to 9 nanogram per mil. Not always necessary. If the remission is maintained, then probably there's no need to monitor this so often. The side effects of tacrolimus are glucose intolerance, tremor, headache, and so on. Both of these agents, if these are effective, we give them for 1 or 2 years or longer, and relapses may occur after stopping treatment. Rituximab is the last resort so far. It is used in patients when all the other agents fail, and there are serious side effects. And we have used in very difficult situations. The child with massive Cushinard features, growth retardation, cataract, and so on. And the dose which we use is 375 mg per meter square per week. We usually give 2 infusions, and when the child is in remission, prednisolone can be stopped, and following this we start the child on mycophenolate. The side effects, acute side effects, are very few, but we need to find out, we have to observe these patients for long periods, and the optimal regimen is being still investigated. Our aim is to prevent complications in nephrotic syndrome. Acute complications are listed here. There's a massive edema, serious infections, hypovolemia, and thrombotic phenomena. A child has, well, this is not too much of an edema, just showing the beginning of it, but this sort of a thing, this massive, huge amount of ascites, and when this situation develops, this is some other problem. The chief problem now is to control the edema, and then we go from there. Mild edema can be controlled only with low salt diet, but when there's an SRC, huge ascites, we have to use these agents. These are Lasix, thiazide, metolazone, aldactone, and large and tense ascites may need to be tapped to reduce intra-abdominal pressure, improve renal perfusion, and occasionally intractable edema, we need to use infusions of albumin. Now, these drugs are very well known, and the clinician, the treating doctor, must be familiar with their usage, the dosage, and problems. Dosage listed here, and occasionally we may use Lasix intravenously, slow bolus for 15 minutes. Chlorothiazide and metolazone act on the distal tubule, while the loop directs are different, and the plan is to use these alone, but sometimes we use Lasix and metolazone, they can be combined. We use one of these two drugs, chlorothiazide or metolazone, to block the distal reabsorption, and we use Lasix an hour later. It's a very powerful combination, but must be used very judiciously, and we must avoid a very rapid diuresis. IV albumin used for intractable anasarca, huge ascites. We use 20% albumin, 1 gram per kg infused over 1 or 2 hours. A rate of fusion less than 2 or 3 per minute. IV Lasix 1 milligram per kg can be given toward the end, and of course you can combine with other diuretics. It must not be given rapidly because there is a risk of pulmonary edema, IV volume expansion. So child must be watched very carefully, monitor the blood pressure and clinical condition. Infections are a serious problem in these patients, but with careful management, serious bacterial infections are not so common now. They can be avoided. The child must be kept in remission. Edema must be prevented, and most certainly massive edema must be stopped, must be prevented. Ensure adequate immunization, pneumococcal vaccine, varicella vaccine. We defer vaccination while the child is on daily prednisolone. We avoid any live vaccine while the child is on immunosuppressive agents. Now, the child with nephrotic syndrome usually looks, well, he may have a lot of edema, but he is not a sick child. He does not look sick. He is playing around and he is going to school. Suspect infection if the child looks unwell. If the child is not well, if he has even mild fever, headache, vomiting, suspect infection. The common infections are peritonitis, cellulitis, and they can appear and spread very, very rapidly. Peritonitis we see mostly when ascites is present. Early features are subtle, mild fever, slight pain abdomen, occasional vomiting. We examine the ascitic fluid, look for white cells and bacteria, exclude other conditions, appendicitis, perforation, pancreatitis, gastritis, they must be excluded, and we use appropriate antibiotics. Child who is in contact with varicella, we use a single dose of varicella zoster immunoglobulin, or if within 96 hours, or the child develops varicella, we use acyclovir 7 to 10 days. Hypovolemia is often seen during relapse. If there is rapid diuresis or diarrhea, vomiting, fluid loss, manifested by tachycardia, hypotension, cold periphery, poor capillary refill, and core to toe temperature difference more than 3, raised hematocrit, urine sodium more than 20. If we suspect hypovolemia, we immediately use saline or albumin to correct it, and it is corrected very easily. Now, thromboembolic episodes are common. The nephrotic state is a hypercoagulable state. It is uncommon, but very often undetected. We do not puncture deep vessels. Suspect if there is asymmetric edema, one side, one limb, one lower limb is much more edematous than the other. Suspect this. Maintain hydration, and cerebral sinus thrombosis is not uncommon in these children, and it may be confused with CS infections and so on. So one should be careful and look for these things. And prompt anticoagulation. A child shown here, he developed brachial plexus thrombosis on the right side. Not very common, but it's all there. Now, the aims of management and eventual outcome in minimal change nephrotic syndrome. Proper management until cure occurs, complete cure around puberty or earlier. Some children may have a little longer duration. Ensure normal growth and development. Prevent complications and iatrogenic problems. We must avoid complications from our treatment. Constant reassurance and emotional support is needed. We tell the parents repeatedly the course of disease and response to medications. All this should be explained to them so they understand what is to expect. Age at cure is not predicted. This is a very common question. The family will ask, parents will ask, When will this be totally cured? This is not predictable, but we can keep on telling them this will go eventually. In a very, very small number of patients, the condition may persist beyond 14 years, but eventually it will be all right. Eventually it will be all right. So to summarize, this nephrotic syndrome is a common condition in children, results from heavy proteinuria. The initiating mechanisms remain unclear. It is again important to mention that why it happens we don't know. What started the whole thing is not known. 90% cases are steroid responsive or minimal change nephrotic syndrome. We do not do biopsy in these patients. They may have a relapsing course, but eventually they will get cured. 5 to 10% of cases have a non-minimal pathology, usually steroid resistant, and overall as a group the prognosis is guarded, and genetic abnormalities are being explored in these patients. Thank you very much.